Today on World of Pain MD, we're diving into a large proposed policy change facing interventional pain medicine. The Centers for Medicare and Medicaid Services, or abbreviated as CMS, have proposed eliminating coverage for many peripheral nerve blocks and radiofrequency ablations. So joining me are two leaders in the field. First is Dr. Zachary McCormick. And to put it succinctly, he's a legend. He's currently professor and vice chair of PM&R at the University of Utah and vice president of IPSIS. His research and leadership have helped shape modern interventional spine and musculoskeletal medicine. Also joining us is Dr. Alex Fogarty, a Harvard-trained, triple board-eligible physician in PM&R, sports, and pain medicine, and a rising voice for innovation and advocacy in comprehensive pain care. And fun fact, she also speaks 3 languages. So together, we'll unpack what these policy changes mean for physicians, trainees, and most importantly, our patients. So thank you so much for watching or listening. Please check out the show notes to find out ways you can advocate for yourself or your patients.
World Pain MD podcast is for information, education, and entertainment purposes only. This applies to all information, graphics, videos, and content on the affiliated website and podcasts. The aforementioned does not constitute medical advice, nor does it establish any patient-physician relationship. The information and content on this website do not substitute for any professional medical diagnosis, treatment, or advice. Seek advice from a qualified healthcare practitioner for any questions you have concerning a medical issue, including treatment. Do not delay consultation with a professional or disregard their advice based on the information on this website. The opinions, statements, and views are that of my own and do not reflect those of my affiliated institutions, policy, or any entity.
Dr. McCormick, Dr. Fogarty, thank you both so much for being here. I really appreciate your time. I know you're both very busy.
Thank you for having us. I think this is an incredibly important topic. So I'm, really happy that you're, to be invited and that you're having us.
Yeah, absolutely.
Excited to get into it and learn something here about a topic that's important and is going to affect all of us.
And speaking of that topic, so today we are discussing the recent CMS proposals for a lot of the peripheral nerve blocks that we commonly do in the pain space. And I wanted to talk about kind of what these proposals were and get into the depths of why that's meaningful and why it's important. So, Dr. McCormick, if you wouldn't mind maybe discussing what these current proposals are.
Sure. So, essentially, there's 7 MACs, which MAC stands for Medicare Administrative Contractor, that essentially they administer Medicare benefits and the Medicare plans, for the American public, for seniors, right? And anyone who's eligible for Medicare benefits. So CMS does not have the man and woman power to actually, administer the benefit of Medicare, right? Healthcare. So these 7 MACs, 5 of 7 of them have proposed new LCDs. LCDs stand for local coverage determinations. And essentially it's policy that's quote unquote local to the territory of that MAC. So you can imagine that if all 7 MACs created a policy that covers the entire United States, 5 of 7 of them covers, 5/7 of the territory or population of the United States. But the MACs have the power to basically change policy for what's allowed under Medicare plans, essentially. So it's probably important to understand, too, that when the MACs do something, the MACs are private companies. So the MACs are not actually the government. They're contracted with the government. But there essentially are 5 companies that run Medicare. One is actually Blue Cross Blue Shield. One is a company called Elevance Health. Another is called GuideWell Source. And the last one is WPS. So this isn't the government. This is actually companies that have been contracted, right, with the government. And so they are, I guess you can do what you want with that. They're looking out for their bottom line in some ways, right? They're companies. And in other words, so when they come out with policy, and it becomes it's technically not CMS's policy. You can have a national coverage determination, NCD, but Medicare has really mostly gone away from this, or CMS has not been doing NCDs. They've generally been deferring to the MACs to create LCDs. And again, when the MACs get together and create, together a common LCD, essentially, which is more or less what's happening right now with these pain procedures, it almost becomes national, like federal level policy. So what these LCDs that have been proposed, they're essentially standardized across the board, and they're proposing to take away coverage. So just stop access completely for an incredible range of different nerve block procedures and radiofrequency ablation procedures that cover hundreds, if not thousands, of unique pain conditions. And these ones generally are focused on the peripheral nervous system. So it would take a long time to touch on every single one of them. But just for example, pudendal nerve blocks, which are important for diagnosis and treatment of pelvic pain disorders. Blocks of various nerves around the shoulder are called out. Occipital nerve blocks, which are implicated in various headache conditions. Genicular nerve blocks, which are helpful for chronic knee pain, either related to osteoarthritis or in the context of someone who's had an arthroplasty, a knee replacement, but they unfortunately still have chronic refractory pain symptoms, which can happen maybe about 10% of the time, or possibly 15% of the time that an individual has a knee replacement. So, and the list goes way on and on. And then ablation procedures, which essentially, coagulating these nerves, whether it's around a shoulder, a hip, a knee, these are also basically the LCDs would propose that they are no longer allowed for anyone with Medicare. And the reality is that if this happens with Medicare plans, and we saw this with about 2.5, 3 years ago with sacroiliac joint procedures, it just gets adopted across the board by commercial payers as well. Why would a commercial plan offer it if Medicare won't? So anyway, this basically, what we saw with sacroiliac joint procedures about 3 years ago was that this was the end of certain block and ablation procedures for sacroiliac joint disorders. So the implications are pretty wide sweeping. And actually, I would call out one more. These proposals have also talked about ending access for various sympathetic blocks. Stellate ganglion, which is often used in the context of upper extremity neuropathic pain syndromes, chronic regional pain syndrome in particular. Same thing for lumbar sympathetic plexus blocks for lower extremity neuropathic pain syndromes, and also CRPS, chronic regional pain syndrome. And these are conditions that there really aren't a lot of options. By the time someone's getting a sympathetic block, they've already failed a range of conservative therapies, physical therapy, oral medications, topical agents, and on and on. So if you now take away the blocks, they're perhaps left with neuromodulation, which can work, of course, but it's a far more expensive procedure, much larger burden on the healthcare system. And there isn't a surgery, right? There isn't like a sort of end stage surgery that can cure CRPS. And that's just one example. I mean, you can basically come up with situations like this, many different pain conditions where this becomes a major issue. So what are people left with? Maybe neuromodulation, very expensive. Opioids, we're trying to move away from that. And then probably realistically just more pain and suffering. So maybe I'll stop there, and we can dig in much deeper into any of these areas for sure.
One question I had too is that specifically what they wrote is that they're not medically necessary. And so I'm curious about what your thoughts are on perhaps why they're thinking they're not medically necessary.
It's a great question. And the truth is, I think a lot of us are puzzled, in the physician community. They've done evidence review, and some of these procedures actually have quite strong evidence. And the best example that's called out in these LCDs is genicular nerve radiofrequency ablation. And there have been some flawed reviews that don't really properly stratify genicular radiofrequency ablation by specific condition for which it's being used to treat, and then also important factors related to the procedure itself. So in particular, lesion size and lesion number. So if you look at globally all of the literature on genicular radiofrequency ablation, you can find studies that say basically it doesn't really work very well. And then you can find studies that say it's amazing and it outperforms and it outperforms basically anything else that, minus maybe total knee replacement, right, for knee arthritis. But of course, there are many people that can't have a TKA, and that's why it's being offered. So or they've already had one and they're still in pain. So it matters how you look at the evidence. And, we see these all the time in pain studies. I think many are familiar with the BMJ review on spinal interventions, RFA. And it was the same problem. Like they just clumped together totally heterogeneous procedures. And so then it just washes out treatment effects when you properly select patients and you perform the procedure in a technically sound way. So basically the MACs in their literature review have not really distinguished between sort of the high quality techniques and those that we at this point know don't really work well. Small gauge electrodes, small number of lesions performed for genicular RFA. So long story short, one, they didn't appraise the literature properly. Two, there are other procedures where there just isn't a lot of literature. Realistically, there isn't a lot of literature. And that's because it's a very rare condition that's being studied. And you're just not going to be able to do 5 randomized controlled trials for phantom limb pain, for example. It's just too hard to recruit those patients. It's not realistic. It's very expensive. So like the evidence burden to say, we have 5 or 10 randomized controlled trials supporting this, and so it's no longer investigational. That's just unrealistic. And so then the MACs basically are using this language. It's not medically necessary because they're saying there isn't enough evidence and it's quote unquote. But if we take a bigger step back and look at, when a physician recommends a procedure and might call something medically necessary, and that's in a much larger context than just what peer-reviewed literature says. So yes, we want to practice evidence-based medicine, but we have to pay attention to the relative risks and benefits of a given procedure and in the context of the alternatives. And if the alternative is expensive surgery or no surgery at all, but just perhaps opioids or lack of treatment at all, and all the mental health consequences that come along with untreated or poorly treated chronic pain, that needs to be considered. If you say, well, there aren't 10 randomized controlled trials, but there are a good number of cohort studies or a couple randomized controlled trials. So this is the trouble with I think we're all puzzled, but the reality is, I think the MACs are looking for areas to cut where there's areas of growth in utilization, and there has been some growth in utilization of these procedures, probably because people are interested in non-surgical options. And a lot of these RFA radiofrequency ablation procedures, the knee is a prime example. It didn't exist 15 years ago. So there was zero utilization. So when the MACs analyze and they look at the trends in utilization, well, of course it's going to be going up because it wasn't even around 15 years ago. So as people understand it and say, hey, this is actually helping patients, they adopt it or they refer for it, and utilization goes up. So they're looking at that and saying, utilization is going up. We need to figure out how to quash that.
Yeah, that is something I wanted to touch on as well. Is this a utilization issue? And with the advent of using ultrasound more frequently, I wonder, being able to identify nerves, is this sort of hand in hand with that?
Yeah, I mean, I think what this is, we're just seeing advancement in our space, where we have better and better minimally invasive treatments, and so that's a good thing, right? Like, patients want that. It's safer than opioids and just a slew of pain medications, or more invasive surgery, et cetera. So I think that's really what it comes down to. And the reality is, we also took a look at the numbers on this. And if you look at just the nerve blocks that are being proposed to be cut, CMS, I believe, last year spent about $25 million on these blocks across the whole country. That's really not a lot of money. There's not a whole lot of savings to be had there by cutting $25 million from healthcare spending, all Medicare beneficiaries. The numbers on I'd have to go pull them, but the numbers for like knee arthroplasty, which to be fair is a good procedure. It's not like there's any competition or comparison, but it's in the hundreds of millions. We'll have to look it up actually and have a proper number. Yeah, but there's not a lot of wiggle for cost savings with these blocks. These are not. This isn't like hundreds of millions or $1 billion in healthcare expenses annually.
Zach, you mentioned something interesting, and I think this theme that's developing is that part of the increased utilization of pain procedures has been that there's been innovation in the space of pain medicine over the last 10, 15, and even 5 years, if you look at the newer procedures on the market. And I think part of that innovation has also been driven, ironically, right, by CMS recommendations to avoid opioids, right? And ultimately, these changes that are supposedly cutting these more innovative procedures are ultimately going to put us back in a place where we were before, which is risking, more addiction in our patients. So it feels like we've taken many steps forwards, but at this point, we're at the precipice, right, of going back to where we were before without really any viable interventional treatments, even though they exist, right, which is the frustrating part, and now left with really no other options than medication management, which may or may not work and definitely comes with another risk. And the other interesting thing I think that's coming to light here is pain medicine is fundamentally a misunderstood space, right? What Zach is mentioning is that ultimately the data for our procedures is never going to be as robust as more common conditions like data for hypertension studies, right, or diabetes studies, because these are rare and challenging conditions with mixed phenotypes fundamentally, and they're also very prevalent if you look at the population as a whole who has chronic pain. So the individual conditions are rare, but the overall burden of pain is really large. So all that to say, I think it's really tough for people to make determinations about what is medically necessary when they're not a practicing pain or interventional physician, because how can you understand that level of depth? So Zach, I was hoping you could expand on who are the people fundamentally in the physician side, right, who are contracted by these companies who are making these really impactful decisions. Are these pain doctors? Are these people who practice in our space, or are these other people, right, who don't maybe know that nuance?
That's a great question. So what I can speak to the limits of my knowledge, but I don't work for these companies. I've never, I don't know that I have ever had a real look under the hood. But I do know that, oftentimes there are medical directors who are physicians. There are medical directors who are physicians in these companies. And they're going to learn as much as they can to try to make decisions to aid with policy development. They oftentimes are not physicians from our specialty. It may be an internal medicine doctor, it may be an OBGYN, it may be an ER doctor, but they don't necessarily have specialty knowledge. There are, some of these companies hire consultants, and they ask, physicians in our community to help them, appraise evidence or develop literature. That's tricky. It's a slightly conflicted role.
Yeah, and we've seen this recently with the BMJ article, whereby, ultimately the outcome of that systematic review was really negative, but the way that the data was stratified and organized didn't make any sense to somebody who ultimately is directly either involved in research or who's seeing those patients, right? And I fear that we're with this coverage determination policy getting to this exact same place where we're lumping together things in a way that is ultimately not reflective of the way that a lot of us are practicing medicine, seeing patients on the day-to-day.
Yeah, and the other thing to pay attention to, I think there's appropriately attention on conflicts of interest, and that's not just in pain medicine. That could be in any field, right, of medicine or otherwise. And of course, if a study is funded by a medical device company or a pharmaceutical company, et cetera, it needs to be disclosed. It's in the manuscript. I think what hasn't gained as much attention is when there's some level of conflict that relates to funding by insurance companies. And that seems to sort of fly under the radar. But there have been more and more studies where there is some influence or a fair amount actually that's coming from insurance company dollars as opposed to medical device or pharmaceutical company dollars. And those disclosures are really potentially just as important for everyone to know for transparency.
And circling back to sort of why this is all important, Dr. Fogarty, if you could speak to how this even impacts, as Dr. McCormick has really laid out well, it impacts patients, but it also impacts our training as physicians and young physicians that are getting into the pain space as well. So I wanted to understand kind of your perspective on that.
Well, I think it's really important for young physicians, whether it's residents, fellows, or early career attendings like myself, to know about these things. I think in the space of our busy trainee lives, ultimately, we're not always aware of these policy things because we feel somewhat shielded from it and we're focused on other things. But I can tell you just as my personal experience just within the space of the last, 2 years transitioning from being a fellow to being an attending, I already learned procedures that are no longer being covered. And one perfect example of that is, sacrolateral branch RFA procedures for folks with, refractory sacroiliac joint pain. And, I can only imagine how this feels when you've been in practice for even longer, knowing that, all of these things that you may have learned are now increasingly being cut. This is just one example, but it's pretty salient because myself and a lot of my more junior colleagues at this point will be learning things that if these rules go into effect, we will no longer be able to offer to patients. So can you imagine going through all that additional training to become a competent interventionalist and knowing how these procedures can help treat your patients and then fundamentally not being able to offer them because of things that are completely outside of your control? I mean, that seems like a really unfortunate place to start your career, from a personal development standpoint and professional development, but because ultimately we're here to help patients and our toolbox has just been radically restricted for us. So I think this should serve also as a call to action for residents and fellows and early career attendings to pay attention to this legislation and do what we can to, voice our opposition, because ultimately this is going to affect us. It's going to affect our patients. And you're going to be learning things that are no longer going to be on the table.
One thing that's really well put. Thank you for that. And one thing within pain that's very frustrating is not having enough procedures or treatments or medications to offer our patients that are dealing with refractory pain, chronic pain. And so now that leaves us in a really difficult spot, like Dr. McCormick was talking about. It kind of leaves us with maybe more expensive procedures like peripheral nerve stimulation. And I was wondering, Dr. McCormick, what do you think about that? I mean, it almost goes to that place where the have and have nots, are the people that actually needed these procedures earlier on just going to be able to pay out of pocket for them? And those that were previously being covered just don't get them anymore?
Yeah, I think that's an excellent point. I think that will be a repercussion of if this policy goes through is these nerve block procedures are not really that expensive. And if many of them, if they're done in an office setting under ultrasound guidance, the cash price, I don't want to say it's inexpensive, but when you compare it to, a surgery performed in the operating room, it might be 1/100th of the cost, potentially, depending on what that surgery is. People will, I think, pain isn't going away, unfortunately. It's not like a policy change is going to change the epidemiology of chronic pain in the United States. And so there are going to be people who are going to pay out of pocket for these things. So essentially, the cost is now being passed along to the Medicare beneficiaries. And you're right, it's just going to exacerbate healthcare inequity, where folks that can afford it, they'll pay out of pocket for that nerve block. And those that they can't, they're going to be really stuck with all the less than ideal options that we talked about earlier.
The other disparity too that it creates, I think that's important to mention, other than the really important socioeconomic disparity that you just mentioned, which is an excellent point, is a disparity of risk, right? So if we're talking about doing a peripheral nerve block in the office versus doing a neuromodulation procedure, and let's be realistic, what most likely is to be approved is spinal cord stimulation or dorsal root ganglion, which are fantastic procedures, but those are fundamentally different in terms of risk level. Those require patients to not be on anticoagulation. Those require patients to have devices placed in the epidural space and ultimately potentially go to a surgical procedure, which requires anesthesia. So the risk level to the patient is also radically different in terms of what we're talking about. And that's on the more invasive side. And on the less invasive side, let's talk about what those risks are too. Those go back to medication management. So we're talking about a Medicare population, folks who maybe already have reasons not to be taking neuromodulation or neuromodulatory medications, whether those are gabapentinoids, TCAs, things that come with risk of falls and all sorts of other cognitive dysfunction and things that, we all are very familiar with. And then, of course, opioids. We don't have to talk about the risk of opioids, but ultimately that risk disparity piece, I think, really needs to be mentioned because these things are not all equal.
I couldn't agree more with that. I would also just add that NSAIDs, NSAIDs are not without risk, and especially in the Medicare population, the issues with hypertension and renal dysfunction, et cetera, are only going to be greater. They are greater in that population.
Sort of in addition to elaborating what's going on here, I think one of the most important parts is what can we do? So what are some things that we can do now as physicians? And then also, if there's any patients listening, what might they be able to do to sort of advocate for ourselves and for them?
So there are a number of efforts that are underway, and I think we do need to multiply them. I can tell you from what I know right now, so Ipsos is in the process of drafting a letter that covers a lot of what we're talking about right now. And the MPW, multi-society pain work group societies that are essentially a coalition of like-minded pain, radiologic, neurosurgical, anesthesiology societies. I might have missed some. Will hopefully sign on. I think many, if all, will sign on to this letter. There's also going to be an invitation for other societies within neurology, rheumatology, sports medicine to also and greater, right? Because this impacts so many different subspecialties within medicine. It's so broad to also sign on. So that's happening. Everybody can comment, whether you're a physician, you're a surgeon, you're a healthcare provider of any type, and frankly, whether you are not in healthcare at all, anybody can comment on these LCDs. And I wonder if we can maybe add a link to this.
Yeah, I was planning on putting it up, and then it'll certainly be in the show notes too.
Yes. Yeah. But anyone can add a comment, and it does not have to be a thorough dissection of the evidence. Right. We're doing that already, but even just as simple as stories about yourself or a family member or a friend who has benefited from these procedures is still helpful. And honestly, it's incredibly helpful, I think, just to spread the word more broadly than the physician community. So people can also call their congressman or woman and let them know, because again, remember, these are private companies that are driving this policy. But the congressmen and women, I mean, they're actually beholden to their constituents, and they should know that this is a huge issue. So if they're getting a lot of phone calls, letters, et cetera, that's helpful. But I think that, also on top of this, whatever everyone does as an individual, as much as they can encourage their, friends, family, colleagues, to also do the same and, multiply the effect so that everyone knows this is going on. I think that's incredibly important. Again, I do not think that the general public has any knowledge that this is going on, and just what an impact it will have if it goes through.
I just want to add again how sort of shocked I am to see occipital nerve block and stellate ganglion blocks on there, because the relief I see from those treatments is just astounding. So I would hate for that to not be covered for our patient populations that need them.
Couldn't agree more.
And Dr. Fogarty, any sort of last words you wanted to add to what we can do to advocate for ourselves?
Just thinking through ways that I think all of us can engage the communities that we're part of is really important. And depending if, you work in private practice, academics, if you're a trainee, your environment and your community is going to be different. And thinking through, is there a way that you can spread the word? One example could be a QR code in your clinic, right, with a link to this, inviting patients and providers, nurses, people who see the real results of these procedures in real time, giving them the opportunity, right, to comment and making it easy, sending out a message to, your residents, sending out a message to your fellows. Ultimately, all of that stuff is going to go, I hope, a long way. So I would challenge everybody to brainstorm about how they can engage the people who are seeing these procedures in real time and who may be patient-facing in a non-physician way as well. I think that's really important feedback to provide. And Dr. McCormick, what's the timeline on this? Like, how fast do we all need to mobilize?
Yeah, so I'll answer that question. And before I forget, there's one other way that I think a lot of people can contribute in a very with minimal time burden. We have a physician colleague in New York who he is working on putting together a petition right now that should be as simple as being able to simply put your name and sign on this petition. And that of course doesn't come along with, an evidence review or with, a story, a personal story or that of a friend or family member. But simply saying, I'm against this harmful potential policy, and being able to provide that to both the MACs, but also to our representatives in Washington D.C. That could be really helpful. It's something that we didn't do that back when this came up a few years ago with sacral iliac joint procedures. And these are the kinds of things that we probably should be doing and need to do now and in the future. And I wonder if we can provide a link to that petition as well. Yeah. I'm happy to put you in touch, Derek, with his name is Hamant Kalia.
Right.
He's at Rochester. Unfortunately, the public comment period ends on November 8th. Where people can submit their comments to the MACs. There's one MAC, and I don't recall which one, where I think it's a little bit later than November 8th, but for the 5, it's November 8th. So we don't have a lot of time left, at least while the public comment period is open. And there are meetings that are being held, open meetings where folks can speak, but there are registration deadlines. And I'll be honest, it happened so quickly. I know many of us missed the deadline to be able to speak at the first meeting that's being held, which is by Palmetto. The other 4 MACs, I know that many societies, Ipsis being one of them, we do have a representative physician who's going to be speaking, about what's going on and in opposition to the proposals at the other meetings, which are in late October to early November.
Excellent. That's super helpful to know. And thank you for bringing that up, Dr. Fogarty. Well, thank you both so much for your time. You both are so busy, and I really appreciate you taking the time to talk about these really important things. And I really appreciate you both standing up for our patients and for our field.
I appreciate the invitation. And again, I'll just reemphasize that this is an incredibly important topic. I think it's a moment for us as a pain community and a broader physician community to really unite on a topic that truly matters and is going to have tremendously negative impact if it goes through.
Thank you for having us and for spreading the word.
My pleasure.